Let me start with something that genuinely frustrates me about how this topic gets handled. Men over 50 walk into their doctor's office feeling exhausted, mentally foggy, less motivated, with a libido that has quietly faded over the past few years and a body that is not responding to exercise the way it used to. They describe these changes, and in too many cases, they are handed one of two inadequate responses. Either they are told these are normal signs of aging, nothing significant is wrong, and there is nothing meaningful to be done, or they receive a prescription for testosterone replacement therapy relatively quickly, without a thorough evaluation of what is actually driving their symptoms or a complete discussion of the risks and alternatives. Both responses fail the patient. The first dismisses real and potentially addressable physiology. The second jumps to a treatment without adequately understanding the problem it is meant to solve. I am Dr. John, and today I want to give you the complete, honest picture of testosterone in men after 50. What actually happens to testosterone as men age, what the difference is between normal age-related decline and clinically significant hypogonadism, how testosterone should actually be evaluated rather than how it often is, what the evidence shows about testosterone replacement therapy, including both its genuine benefits and its genuine risks, and what the substantial range of non-pharmaceutical interventions can accomplish for men whose symptoms are real but who are not candidates for or are not interested in hormone replacement. Before we begin, leave a comment with your age and whether you have ever had your testosterone level tested and been given a clear explanation of what the result meant for your specific situation. I read every comment, and your experience with this topic specifically informs what I address in future conversations. Let me begin with the physiology. Testosterone is produced primarily by the Leydig cells of the testes, with a small contribution from the adrenal glands. Its production is regulated by a feedback loop involving the hypothalamus and pituitary gland. The hypothalamus releases gonadotropin-releasing hormone, which signals the pituitary to release luteinizing hormone, which in turn signals the testes to produce testosterone. When testosterone levels are adequate, this feedback loop down-regulates the signal. When testosterone falls, the feedback loop increases stimulation. Testosterone in the bloodstream exists in several forms. A small fraction, roughly 1 to 3%, circulates as free testosterone, biologically active, and able to enter cells directly. A larger fraction is loosely bound to albumin and is also bioavailable, meaning it can be released and used by tissues. The majority is tightly bound to a protein called sex hormone binding globulin, or SHBG, and is not biologically accessible to tissues. The total testosterone measured in a standard blood test captures all three fractions together. After approximately 35 years of age, total testosterone typically declines at a rate of roughly 1 to 2% per year on average, though the range across individuals is genuinely wide. By 60, many men have total testosterone values that are meaningfully lower than they were at 35. This decline is real and has biological consequences, but it is a gradual, continuous process rather than a sudden drop, and it exists in the context of normal aging rather than necessarily representing disease. What complicates interpretation significantly is the parallel rise in SHBG that occurs with age. Because SHBG increases as men age, a larger fraction of the available testosterone is bound and biologically inactive. This means that even when total testosterone appears within the normal range on a standard blood test, the biologically available fraction may be meaningfully lower than the total number suggests. This is one reason why total testosterone alone is an inadequate measure for evaluating symptoms in older men. Free testosterone and calculated bioavailable testosterone, which accounts for both the free fraction and the albumin-bound fraction, provide a more clinically relevant picture of what testosterone is actually doing in the body. Men whose symptoms suggest testosterone deficiency and whose total testosterone appears borderline often have more clearly low free or bioavailable testosterone when these are properly calculated. The distinction between normal age-related decline and clinically significant hypogonadism matters for treatment decisions. Clinical hypogonadism describes the state in which testosterone levels are sufficiently low and associated with specific symptoms that treatment is likely to provide benefit. The operational definition involves both a biochemical threshold, typically a total testosterone below 300 nanograms per deciliter confirmed on at least 2 measurements on morning samples, and the presence of specific symptoms attributable to testosterone deficiency. The symptom requirement matters because testosterone levels in the laboratory tell you only part of the story. Different men have different sensitivity to testosterone at the tissue level. Some men develop significant symptoms at levels that others tolerate without difficulty. The combination of low measured levels and specific attributable symptoms is what defines clinical hypogonadism rather than a laboratory number alone. The symptoms most specifically associated with testosterone deficiency and most likely to respond to testosterone treatment include reduced libido, with changes in sexual interest and sexual function, loss of morning erections, which are largely testosterone dependent in their occurrence, loss of muscle mass and strength disproportionate to aging and physical activity level, increased body fat accumulation, particularly visceral fat, reduced bone density, hot flashes and sweating, which occur in some men with significantly low testosterone just as they do in women during menopause, and mood changes, including reduced motivation, decreased sense of well-being, and in some cases, depression specifically associated with the onset of low testosterone. Symptoms that are less specifically associated with testosterone and may have many other causes include fatigue, poor concentration, sleep disturbance, and general malaise. These symptoms are so common and have so many potential causes that their presence alone provides relatively limited evidence that testosterone deficiency is the driver. Men whose primary complaint is fatigue or cognitive fog, in the absence of the more specific symptoms listed above, typically warrant a broader evaluation rather than jumping immediately to testosterone as the explanation. How should testosterone actually be evaluated? The first and most important principle is that a single blood test is insufficient for diagnosis. Testosterone has significant diurnal variation, being highest in the early morning and declining through the afternoon, which means that a testosterone level drawn at 2 in the afternoon may be meaningfully lower than the same man's testosterone drawn at 8 in the morning. It also varies day to day and is affected by acute illness, stress, and other factors. The standard recommendation is that at minimum 2 morning testosterone measurements, drawn between 7 and 10 a.m. and separated by at least several days, should be used before making a diagnosis of hypogonadism. The evaluation should also include luteinizing hormone and follicle-stimulating hormone to characterize whether the problem, if present, lies at the level of the testes or at the level of the hypothalamic pituitary axis. Low testosterone with appropriately elevated LH suggests primary hypogonadism, a problem with testicular function. Low testosterone with inappropriately low or normal LH suggests secondary hypogonadism, a problem with the regulatory signals from above. This distinction matters both for understanding the cause and for considering treatment options. SHBG should be measured to allow calculation of free testosterone, which, as discussed, provides a more clinically relevant picture in older men than total testosterone alone. A complete blood count is important because testosterone stimulates red blood cell production, and men on testosterone therapy can develop erythrocytosis, an excess of red blood cells that increases clotting risk, making baseline hematocrit important before treatment begins. Prolactin should be checked because elevated prolactin, which can result from a benign pituitary tumor called a prolactinoma, among other causes, suppresses testosterone through the hypothalamic pituitary axis and is an important treatable cause of secondary hypogonadism. Thyroid function should be checked because hypothyroidism produces overlapping symptoms, including fatigue, reduced libido, and altered body composition that can be confused with testosterone deficiency. Metabolic factors including fasting glucose, HbA1c, and a lipid panel are relevant because insulin resistance and metabolic syndrome are strongly associated with reduced testosterone, and addressing these through lifestyle may improve testosterone levels without requiring hormone replacement. This evaluation takes several measurements over a period of weeks and considers the full clinical picture. Men who receive a testosterone prescription after a single afternoon blood draw without this broader assessment have not been adequately evaluated. What does the evidence actually show about testosterone replacement therapy? The evidence has clarified considerably over the past decade, with large randomized trials providing data that was previously unavailable. The testosterone trials, a coordinated set of 7 trials funded by the National Institutes of Health, enrolled men over 65 with confirmed low testosterone and symptoms. The trials demonstrated benefits in several domains. Sexual function, including libido, sexual activity, and erectile function, improved significantly in the testosterone group compared to placebo. Physical function showed modest improvement, including increased walking distance. Bone density increased measurably, particularly in the spine and hip. Anemia responded favorably in men with unexplained mild anemia, and depressive symptoms showed some improvement. What the trials did not demonstrate definitively is the cognitive benefit that many patients and clinicians expected. Cognitive outcomes did not clearly separate between testosterone and placebo groups across most measures, which has tempered enthusiasm about testosterone as a cognitive enhancer in older men, at least at the doses and durations studied. The cardiovascular risk question has been the most contentious and most intensively studied aspect of testosterone therapy, and it deserves careful, honest discussion. Earlier observational studies produced conflicting results, with some suggesting cardiovascular benefit and others suggesting harm. The biological rationale for concern is real. Testosterone therapy increases hematocrit, potentially increasing clotting risk. It can affect lipid profiles. And the population of men most likely to receive testosterone therapy, older men with cardiovascular risk factors, is inherently a higher risk population in whom adverse events are more likely to occur regardless of treatment. The TRAVERSE trial, a large randomized controlled trial specifically designed to assess cardiovascular safety of testosterone therapy in men at elevated cardiovascular risk, found that testosterone therapy did not increase the rate of major adverse cardiovascular events, including heart attack and stroke, compared to placebo over a 4-year follow-up period. This was genuinely reassuring data that addressed the most significant safety concern. However, TRAVERSE did find a higher rate of atrial fibrillation, a cardiac rhythm abnormality, pulmonary embolism, blood clots in the lung, and acute kidney injury in the testosterone group compared to placebo. These findings were not large enough to affect the primary cardiovascular endpoint, but they were statistically meaningful and clinically important. Men with existing atrial fibrillation, prior thromboembolic events, or significant kidney disease are not appropriate candidates for testosterone therapy based on this data. Prostate considerations remain part of the safety discussion. Testosterone therapy is contraindicated in men with known or suspected prostate cancer, given that prostate cancer is androgen sensitive and can be stimulated by testosterone. PSA should be measured before starting therapy and monitored during treatment. Men with baseline PSA above 4 nanograms per milliliter or above 3 nanograms per milliliter in high-risk populations require urology evaluation before testosterone therapy is initiated. The historical concern about testosterone therapy causing prostate cancer in previously healthy prostates is now considered less strongly supported than it once was, but the contraindication in men with known disease remains firm. Erythrocytosis, the excessive production of red blood cells in response to testosterone stimulation of erythropoietin, is the most common laboratory abnormality associated with testosterone therapy. A hematocrit rising above 54% is a clinical threshold, typically prompting dose reduction or temporary suspension of therapy, as elevated hematocrit increases the viscosity of blood and the associated risk of thrombotic events. Fertility effects are relevant for men of reproductive age. Testosterone replacement suppresses the hypothalamic pituitary testicular axis, reducing endogenous testosterone production and dramatically reducing sperm production. Men who wish to preserve fertility should not receive standard testosterone replacement therapy without explicit discussion of this consequence and consideration of alternative approaches, such as selective estrogen receptor modulators or gonadotropins that can raise testosterone while preserving sperm production. Sleep apnea can be worsened by testosterone therapy, which is relevant given how common undiagnosed sleep apnea is in the population most likely to receive testosterone prescriptions. What about men who have real symptoms but whose testosterone levels are borderline or whose clinical picture does not clearly indicate hormone replacement as the appropriate intervention? This is where lifestyle and non-pharmaceutical approaches have genuine and substantial evidence that is consistently underemphasized relative to the pharmacological conversation. Body weight and visceral fat have a powerfully bidirectional relationship with testosterone. Adipose tissue, particularly visceral fat, expresses aromatase, the enzyme converting testosterone to estrogen. The more visceral fat a man carries, the more testosterone is converted to estrogen rather than remaining as testosterone, and the lower his effective testosterone environment becomes. Weight reduction in overweight men consistently raises testosterone, sometimes substantially. Research has found that meaningful weight loss produces testosterone increases of approximately 100 nanograms per deciliter or more in some studies. In a man with a borderline testosterone value and significant visceral fat, meaningful weight loss may normalize testosterone without any hormone replacement. Resistance training is the most potent non-pharmaceutical stimulus for testosterone production available. Intense resistance exercise, particularly exercise involving large muscle groups at relatively high intensity, acutely raises testosterone and growth hormone levels. Over time, men who maintain regular resistance training programs have measurably higher testosterone levels than sedentary men of the same age. The relationship between muscle mass, physical activity, and testosterone is bidirectional. Low testosterone reduces muscle mass, and reduced muscle mass and activity reduce testosterone. Intervening with resistance training breaks this cycle in the favorable direction. Sleep quality has a direct and substantial impact on testosterone production. The majority of daily testosterone production occurs during sleep, concentrated in the slow-wave and REM sleep stages. Research has demonstrated that even 1 week of reduced sleep duration from 8 hours to 5 hours per night reduces testosterone levels by 15% in healthy young men. In older men with already reduced testosterone, chronically fragmented or insufficient sleep further compromises production. Men presenting with low testosterone symptoms who are sleeping 5 to 6 hours nightly or whose sleep is significantly fragmented by apnea or other causes should prioritize sleep optimization before interpreting testosterone levels and considering replacement. Stress and cortisol suppression represent another genuinely significant and often overlooked factor. Chronic psychological stress maintains chronically elevated cortisol, and cortisol directly suppresses gonadotropin-releasing hormone at the hypothalamic level, reducing the entire downstream cascade of testosterone production. Men under significant sustained psychosocial stress who present with low testosterone symptoms may have stress-mediated suppression as a primary contributor. Addressing the stress through whatever effective means are available, whether therapeutic, lifestyle-based, or social, produces measurable improvements in the hormonal environment. Vitamin D sufficiency is associated with testosterone levels in multiple observational studies. Vitamin D receptors are present in the Leydig cells that produce testosterone. While the evidence for vitamin D supplementation improving testosterone in men who are not deficient is weak, correcting genuine vitamin D deficiency, which is very common in older adults in northern latitudes or with limited sun exposure, may contribute modestly to improving testosterone in men who are deficient. Zinc sufficiency is relevant because zinc is required for luteinizing hormone receptor function and for several enzymatic steps in testosterone synthesis. Zinc deficiency, which can develop from inadequate dietary intake or increased loss through sweat in physically active men, is associated with reduced testosterone. Men with confirmed zinc deficiency should correct it through dietary sources or supplementation before attributing testosterone reduction to other causes. Let me close with the practical framework I want you to take forward. If you are experiencing symptoms consistent with low testosterone, specifically reduced libido, loss of morning erections, significant unexplained muscle loss, increased visceral fat, or mood changes including reduced motivation, these symptoms warrant evaluation rather than either dismissal or immediate hormone prescription. Evaluation means at minimum 2 morning testosterone measurements with calculation of free testosterone accounting for SHBG alongside LH-FSH, prolactin, thyroid function, metabolic markers, and a prostate screen including PSA. Before interpreting those results as indicating a need for hormone replacement, consider the lifestyle and physiological factors that influence testosterone independently. Sleep quality and duration, body weight and visceral fat, resistance training history, chronic stress level, vitamin D and zinc status. If after thorough evaluation, including optimization of reversible contributing factors, testosterone remains clinically low with specific attributable symptoms, testosterone replacement therapy may be appropriate. The conversation about it should include the specific benefits demonstrated in trials, the specific risks including erythrocytosis, potential atrial fibrillation, effects on prostate, and fertility considerations, and the monitoring that appropriate therapy requires. Testosterone therapy in appropriately selected and appropriately monitored men produces genuine benefits. In men who are not appropriate candidates or who have not had their reversible contributors addressed, it adds pharmaceutical risk without maximizing the potential of what lifestyle optimization can accomplish first. The goal is not always a prescription. Sometimes it is understanding what is driving the symptoms well enough to address those causes directly. And sometimes, after thorough evaluation and appropriate conservative intervention, it is a prescription that is genuinely indicated and genuinely beneficial. You deserve to understand which category you are in. This is Dr. John. Know your hormones as well as you know anything else about your health. I will see you in the next one.